Thank all of you so much. That was really great, and I think really helps to set up the day for us, thinking about these important issues and what's been done and what we can do next. So I hope others will ask questions, but I thought I'd start us off with one. Um, Brandon, that was really helpful to see your top 3 recommendations, and I wanted to ask a similar question to the rest of the panel. If you're thinking about the future and moving forward with adolescent and young adult oncology, and particularly around this idea of prospective studies, what do you think we need to do? What do we need to create in order to allow for good studies moving forward to better understand and then address the needs of the adolescent young adult oncology population?
One option I don't think I heard as much from Brandon as I might have liked is that when he said there's so many different models locally being developed of AYA units, of programs. He mentioned Teenage Cancer America, but that would be just mainly for teenagers. But there are many other models across the country and in Canada, and of course internationally. And I don't think there's a central location to understand how those models are being developed and the challenges that have occurred. A clearinghouse, a place where we can learn from each other in terms of actually putting together AYA programs. So I would like to consider, in terms of the next development phase, a way of learning from each other what the lessons are to do that. They're still independent of each other by and large. There's no central process that I'm aware of.
I would second that, Archie. I think from the psychological perspective, I think as much as we have shared in organizations such as the Adolescent Young Adult Alliance and Critical Mass, I think there are still many institutions that are functioning sort of on their own, and to have some central place where we could disseminate programmatic issues that were studied and evidence-based for this population for the psychological aspects would be a really big step. And also, I still think we have a lot of work to do to create tools to assess the psychological and developmental issues for adolescents and young adults with cancer, so that we can really have an evidence base that's based on validated tools.
Maybe just to stress my first bullet point, back as we were preparing the 2006 PRG report and dreaming about what if we had the Institute of Medicine create a workshop, one of the pipe dreams were things like, well, what if there was an adolescent and young adult cooperative group where that was the central hub for research? I think we all recognize that that's not realistic. But coordinating those efforts through existing mechanisms, such as the National Clinical Trials Network, to build collaborations between the Children's Oncology Group and the adult cooperative groups, to support the internal working groups at the NCI and the champions that have existed at the CDC, where a lot of these programmatic and research hubs exist, to allow them to create AYA-specific platforms, I think is important.
Tom, did you want to ask a question?
Yeah, just very quickly. I'm not sure if we're going to get to this in the agenda later, but all of you all made some allusion this morning to the fact that providers aren't necessarily well prepared or well positioned to deal with some of the issues that you've raised in this particular age group. I wonder if you could say just a little bit more about the context of that and whether you see that improving dramatically, improving marginally. Are you all voices in the wilderness for this thing? Or is there a mass movement underway that you would likely see some of the changes you want to see in a dramatic way? Or is there more attention needed to those areas?
We're not entirely out in the wilderness, because there have been developments to allow us to understand how to move into this AYA oncology field, arena, discipline, specialty, whatever we're going to regard it. In terms of training, you heard about Brandon's publication and also one by Siegel et al. In terms of the requisites to develop a good AYA unit. There have been evolving specialty training programs, even fellowships, although there are very few. So we're moving forward. It's very slow, but I think it's in the right direction. I think, again, coordinating the effort of trying to do a fellowship program here and one over there, and they're so different from each other, and dealing with the business plan I mean, Brandon's emphasis was on research, but just in terms of the primary problem of setting up a unit that's self-sustaining, can deal with the insurance, referral issues, clinical trial entries, philanthropy, units that have now benefited from major gifts of donors and grateful parents and so forth. All that's fragmented. It's entirely uncoordinated. It's everybody's on their own. And I think we're learning different lessons and learning them over and over and over again. The duplicative effort, that's what I meant by an earlier point of view. Even those training programs which are cropping up are unlike the next one. So I think coordination of that effort from the practical aspect, not the research so much, although I'm totally focused on research, the business plan of trying to cope with the friction between the adult and pediatric services, between the dean who has to take care of his departments and the president and the chancellor of the university who has to look at the bottom line. All that needs, I think, some learning from each other.
Yeah, I mean, to echo some of that, I think part of my thinking around really a need for the field to document what outcomes are important and how we're having an effect is to be able to do that. Right now, if I go to my dean, I need to be able to explain why a fellowship matters or why a unit matters or whatever. So I think that's important. But I think getting back to your question, I think there are some very specific concrete examples where there has been a change. And just a level of awareness was enough to do it. So for instance, fertility preservation, I think has gone from, gee, I sure hope my doctor thinks about it, to really a mandate. And hospitals like mine have policies in place where oncologists must give information about the risks of fertility and offer potential preservation options. So I think there are very tactical examples like that where that's going to disseminate across the entire oncology field, and there doesn't necessarily need to be an AYA specialist to manage that. It should be everywhere. But I think there are going to be specific examples where there's expertise in a particular cancer that overlaps between pediatric and adult, and there really is an opportunity for an AYA expert to exist. And right now, sort of how you define that and what the training requirements for that is still in evolution. But I certainly hope that over the next 5 to 10 years, we would see that being formalized.
I'll take a question over here.
Sharon Murphy, here at IOM as a scholar, and certainly excited about the topic here. It's one close to my heart as well, having shared many years in the field with Archie and others. I wanted to go back to this database issue and just comment a bit. This is an age group, obviously, that's very wired. They're online all the time. And I don't think we should worry about deans or, department chairman or anything. We should go to the patient. This is the most important. So it has to be patient-centered, and these individuals at this age anyhow are constantly on Facebook and they're sharing everything. And there are some models, and I'm wondering whether you have considered, or maybe you are already doing something like the tremendously successful Patients Like Me that Jamie Haywood has put forth as a platform for neurologic diseases. And why don't we have a Patients Like Me website that basically could be driven by the individuals of this age group who are experiencing, and they could go online, see about Patients Like Me. You could collect the outcomes. Jamie does research on all of this. And you could also have this way of updating in real time how patients are doing. This would be patient-centered. They could share late effects, toxicities, results, quality of life. It would be a fabulous idea. Are you doing this, or are you thinking, or is this already your database?
Definitely hugely interested. I think there's a lot of challenges to how you get from that idea to making it happen. But yeah, I think certainly speaking on behalf of Critical Mass, looking at sort of the next evolution of that alliance gives a real opportunity, because in fact you have a group of of academicians and researchers who can help, appropriately design that environment so that you can pull it out, but you also have the advocate communities there. So we see that as a potential home for that kind of effort.
Again,
But I would let it be patient-driven.
and there are such models, but again, they're fragmented and we don't know all about them. The Teenage Cancer Trust has developed the application for iPhones and for smartphones and so forth. And there are multiple examples of that in the United States too, but I'm not sure they're going to be discussed here. So bringing those together, yeah.
Yeah, at Dana-Farber, we have a website platform for our young adult patients, and it's less in the research area and more in the connection and peer support. And it was developed by young adult patients themselves, and is a platform that could be used in multiple centers across the country if we could sort of cross the barriers that we need to cross to have that be available.
Great, yes.
Renzo Canetta, Bristol Myers Squibb Clinical. I have a couple of questions for Archie for the statistics that you presented. One thing that was particularly striking was the increase of nasopharyngeal carcinoma in the pediatric population or in the young adult population. Is that a reflection of migration patterns coming from Asia, where this tumor is particularly prevalent?
Nasopharyngeal carcinoma was actually not on the list in terms of a clear increase or statistically significant increase, but I do know it is increasing, especially in females between the ages of 25 and 40, 45, and some of that has to do with HPV transmission, as we know. As far as the Asian influence for nasopharyngeal carcinoma per se, not oropharynx or oropharyngeal, that category has not been deliberately examined because it's a small group. So yes, I think you're right, there's an increase. Is it due to influx, immigration of races or ethnicities that are predisposed? I don't know, but that's something that could be done relatively quickly with help from the SEER program.
And
I don't know the answer.
The second question has to do with the increase that you have shown across the board for renal carcinoma, including also adolescent and pediatric population. Does that include also Wilms tumor that have been included by mistake into the renal cell carcinoma or not?
No, I doubt that Wilms tumor is contributing much of anything to that because of the small proportion compared to kidney cancer, renal cell carcinoma, and particularly in the other carcinomas. So I don't think Wilms is increasing, but that was not specifically looked at because it's less than 0.1% of the AYA cancers, and we focused on those. I'm not aware of any obvious increase in Wilms tumor per se.
And the third thing actually is a comment on what Sharon was alluding to. It seems to me that there is an aspect of young adult and adolescent survivorship and care that is very important also in terms of restoring this patient to a full, productive, normal life. So there are financial aspects that I think have not been appropriately delineated because these are people that can return to normal life, productive life, and they're not a burden to society, but are contributing to society.
Absolutely, and that's an answer all three of us should probably yield to. I'll just pick on insurance. If lack of health insurance is the most common cause of family and individual bankruptcy, and these are children now, 6 million, not children, young adults who were children, who have insurance, I think we're going to help with their financial outcomes. But nonetheless, not being able to be educated, not getting a college degree, not being employable, that's going to still be a problem despite the Affordable Care Act. But I think the Affordable Care Act is helping in that regard.
Hi, Laurel Barash from the Norris Comprehensive Cancer Center in LA. Archie and Brandon, you both mentioned the importance of documenting outcomes and evaluation. And our program is currently in the implementation phase. And I'm wondering, are there currently any AYA oncology metrics that programs like ours can be focusing on to contribute?
There's not a ready tool. There are definitely categories of dimensions of service for an adolescent young adult oncology patients to examine. So at our institution, we sort of have this 10 dimensions that we look at. But I wouldn't say that there's a uniform tool that's been applied across programs. I think that's a need.
Is there a recommendation, I suppose, at this point, fertility, or is there like a top 3?
So Archie is talking about the article. So the article actually that Brad Zebrak was the lead author of in JCO that talks about the quality care components. You'll hear more from Rebecca Block about work that she has done that where she took a look at those components. She took a look at the guidelines from NCCN and a couple of other sources of sort of what the components would be, and actually did a survey of programs that are starting up in adolescent young adult oncology to take a look. So I think there's an effort to have that evolve into a formal tool, but it's not there yet.
Okay. I had one more question for Archie. You mentioned the increase, I think you gave a specific example of thyroid cancer and how there might be some over-treatment and over-diagnosis. And I'm wondering how that's juxtaposed with the AYA population, which has historically been sort of misdiagnosed or underdiagnosed. What's the balance there?
Yeah, that's a challenge in many cancers, especially breast cancer, prostate cancer, for screening of disease that does not need to be diagnosed or treated. I'm not as familiar with the problem with thyroid cancer as I am with the other cancers I just mentioned, but it is a balance. Screening for thyroid cancer is helpful for those who deserve and would benefit from treatment. On the other hand, we're over-diagnosing too many to get the few that do benefit, and are willing to allow them to go through radioiodine therapy and or surgery, and even other modalities. Now there are new drugs available, though those are usually not used in this setting, to be able to treat the few that do need it. And that balance of under and over diagnosis is a real challenge in all the cancers that I just mentioned, but I'm not sure where we are with that with thyroid cancer. Maybe Otis Brawley to my far right and your left might have some answers from screening point of view, but it's a good question, not a good answer.
Hi, David Fryer from Children's Hospital Los Angeles and the University of Southern California. Brandon, in your presentation, I think implicit, but perhaps not so easy to recognize, is actually how important the PRG itself has been in propelling this field forward. I think by almost any measure in the past 10 years, barely 10 to 12 years since the field of AYA was really highlighted, it's seen tremendous progress. And I think the Progress Review Group has actually, that publication has had a lot to do with that. It's been very helpful, I think, for us to have something very specific to refer to as a benchmark and against which to judge our progress. I think my question for you and perhaps Archie most, and maybe some members of the audience, is what comes next? The PRG can continue to serve as a benchmark to some extent, but we now have priorities that have evolved as a result of the work that's been done and are not articulated specifically in that PRG. So the question is, what sort of document can we now develop that we can turn to that can serve as a benchmark, for the next 5 to 10 years?
I think that's well said. I think all of us in the field totally agree that that PRG report has been a benchmark and has really spurred on a lot of the progress and development that we're seeing. I think, those of us in the field are excited that, here we have one summer where the National Cancer Policy Forum is holding a workshop and will publish proceedings, as well as the NCI doing a follow-up workshop on the research priorities. And I think an amalgam of those two events this summer is probably as close as I can think of as to sort of the next document of where is the field and what the priorities and needs are. But definitely, I think we all recognize that having that sort of central tool to look back to and say, well, we're responding to that has been really helpful.
David, I'd like to add that of all the PRGs that were done, the last of which was on AY oncology, and the first 14 of which were disease-specific, and there was one, I think, on minorities or disparities. It's the only one that's had a follow-up meeting like this. It's the only one that came out with a set of implementation plans that the Livestrong Young Adult Alliance has been carrying out, and now the critical mass. So, I mean, it's amazing. Of the 14 or 15 or 16, this is basically it. So of all the PRGs, we're here because we're persistent, which is what Roosevelt's wife said, right? Well, perfect quote. I do want to mention, and I'm going to come back to I can see it, you may not anymore, the #1 research priority that Brandon mentioned. I want to mention that this is such a broad age range that you almost have to look at the individual narrow age ranges. For example, 15 to 19-year-olds, there will be 6 or 7 publications, all in the issue of pediatrics, that the CDC arranged, and that'll be out hopefully later this year, early of 2014. So there are other publications coming. It wasn't coordinated by the PRG, it was the CDC. So now I want to come back to this question, especially for those in the government and the Institute of Medicine. I was surprised to see that Brandon's #1 research priority is to get the NCI and the CDC to collaborate, to formalize their internal efforts. So here you have somebody in Atlanta working for the CDC on the 15 to 19-year-olds. Then you have another group in Washington, the District of Columbia, at the NCI working on this, including September's effort. By the way, you better check with Ashley Smith and Anita Seibel about whether you can go or not, because there's an issue of funding, and I suppose you live in Washington, you just show up. Ask Ashley, or Ashley, tell us what's going to happen. Anyway, the fact is, I am impressed and been struck by the lack of cooperation within government between the Centers for Disease Control and the National Cancer Institute. Neither of the other knew what they were doing. That's my impression. If Eric Tai wants to say something about that, he's in the audience. So, I mean, that's got to be fixed.
Just to clarify, though, Archie, that's not really what I meant by that priority. What I mean by that priority is to support those efforts that are ongoing at both the NCI and the CDC. I think that, again, that PRG process was what got us here. And that was led by internal champions at the NCI that need to be supported, and that effort needs to continue and be funded. I think, obviously, part of the other reason the PRG was so successful was the partnership with the Livestrong Foundation to fund an implementation body as well. Yeah. So the notion that government's not going to do it alone, or that independent organizations, nonprofit organizations aren't going to do it alone, or medical institutions aren't going to do it alone, obviously we're going to need to work together. But I think from a policy perspective, supporting that there are internal working groups focused on these needs of adolescents and young adult oncology across the relevant agencies, both the CDC and the NCI, is definitely my #1 priority.
My #1A priority is to get them to collaborate as well.
I'm Lenny Sender from UC Irvine. To answer to Sharon's question, there are actually quite a lot of organizations that are similar to patients like me. Recent one is Smart Patients that came out by Ronnie Ziegler, who was one of the Google Health executives, which is really the concept of getting smart patients to crowdsource research. And it's actually very interesting in collecting very good groups of people to assist their physicians in how they're doing research. The concept of, in the new patient-centered world, the patient is also a researcher. It's not just us who are doing research. I know that some of the other organizations are doing that as well. In terms of also getting back and saying where are the models, in the Journal of Adolescent Young Adult Oncology, which I'm the editor, we are starting to come out with a series of papers, and we'll continue to do them where people can publish their models. So we're looking at the Canadian model, we're looking at the Italian model, we're looking at some of the American models. So again, there are forums now that people can start publishing that like data. And lastly, I'd like to ask actually Dr. Gant's question. With a very important study being done called the Athena breast study, which is going to look at 400,000 women with breast cancer. If we really have matured from the PRG to now, then the questions are we asking relevant questions of the AYA population who have breast cancer in that study when we're going to fund these big studies and do these studies? And I think we are, but maybe Dr. Gans can just enlighten us.
First of all, for those of you who don't know, Athena is a project of the 5 UC, University of California, cancer centers to look at an inception cohort of women being screened for breast cancer with screening mammography and then follow-up. There are by no means 400,000 enrolled. It's probably...
That's the goal, right?
I don't think it's a realistic goal. It was on a paper goal, but there may be, if there are 30,000, that's the issue. And the issue is we are collecting data on women with regard to their risk, so when they're being screened, but very few of them are cancer patients. So I think it's premature to have that be an issue really for this. And Athena is kind of a digression from this, so I'll just leave it at that.
I'll add, Lenny, I spent a half a day with the Athena group in San Francisco, who, by the way, in terms of who I met, were between 20 and 40, very young. But they're got AYA or at least YA very much in mind. I'm not worried.
By the way, AYAs are not being screened, okay? The age of
Right, you gotta be
screening
under-
mammography is 40, as you saw from.
No, it should be
the
50. Let's start
But
from
we're
that.
not. But we're not screening AYAs. So that's another. I should have just said that right off the bat.
Hi, Larissa Necleta from Harvard Vanguard Medical Associates and Harvard Medical School. I'm wondering about, just the very wide age for the AYA definition, and wondering to what extent the age groups have actually been broken apart, because, there are implications in terms of who these patients are being seen prior to diagnosis of cancer, where they're being referred to after they're diagnosed with cancer, what their psychosocial needs are, what their developmental needs are, et cetera. And so I'm just wondering, are we really doing an injustice by lumping them all together?
I think it's a really great point, and the work I do is primarily in the medical oncology setting. So I am running a program that is just in the medical oncology setting and that does not involve the pediatric setting. So, but I know really it depends on the institution and the structure of the institution, how big these questions are and how the structure of some of the programming sort of gets played out.
But even in terms of looking at the data, breaking up the data segments a little bit.
Definitely a risk of not justifying or doing social injustice, which is why I mentioned you had to be very careful about the age application. But again, I think because the institutional models, even though they're being published in the Journal of Adolescent and Young Adult Oncology, there's a forum for that. There's no effort to try to bring it together so that we're not all duplicating what others have tried. What's going on in Boston and Los Angeles are more similar than different. What's going on in Seattle and Atlanta and Miami are similar to what's going on in Italy and Sydney and Fairbanks. So I really think there needs to be a forum, and maybe the critical mass is the appropriate place, but critical mass starts at 20 because it's meant to be young adults, or 18, let's say. So even that has limitations, but at least it's an appropriate place for at least their meeting a year from now. The one in Cleveland is in November. Maybe it'll be there. I don't know, but we really, these questions you've asked all come back to, well, we haven't figured out how to do this together. Whether it's social media, let the AYAs themselves, like the HIV group did, they solved a lot of their problems on their own, and then the breast cancer organizations followed. The AYAs should be doing the same, but how to coordinate it, support it, and give them a platform to work off. That's, I think, what we have to consider.
Just quickly, so critical mass that goes by the same definition, starting at age 15.
15, okay.
I think there's no question there's a wide array of development that happens between 15 and 39 that are going to affect cancer outcomes. But if you look at the field of pediatrics, there's a very wide array from birth to whatever, 18, 21, whatever it is. So I don't think that should be a limitation. I think the real challenge is to pick apart, and again, just like in pediatrics, there may be age segments, but to pick apart what is unique, what is distinctive, and what is impactful on outcomes. whether that be within cancer or even more broadly. So, yes, right now, there's sort of this dichotomy of where a non-cancer patient may present, right? But to recognize that there's going to be unique developmental and life stage aspects that are going to affect their care, so that those are recognized early, and that when a cancer diagnosis is thought of or made, that then that leads to a referral to an AYA cancer specialist. I mean, again, I think in terms of PRG pipe dreams, the notion that there would really be a cadre of adolescent and young adult specialists, particularly within oncology, who are sensitive to the unique tumors and those unique developmental needs, even though there's going to be a range. Not everyone's going to know everything about thyroid cancer and breast cancer and ALL, but to have a general familiarity of what those issues are during that age range, noting that there's going to be breakdowns.
Let's take one last question.
Nita Seibel from the NCI, and I just wanted to follow up on this. In preparation for the meeting in September, we are breaking out, particularly for different age range, for outcome, epidemiology, and different things, because obviously there's a vast difference in the number of the types of tumors you see in 15, 19-year-olds and older. And then I just wanted to emphasize one statement that Brandon said, and this was related to the PRG, and this was an example of a private-public collaboration. And what we're doing or have done could not have been done without Livestrong. So this is really a model that should be, sort of touted and really, used to go forward in the future, because obviously we all know what the state of government funding is right now.
This function is also a model of private and public partnership, what we're doing in this room. And I guess I want to add one point before we leave for the break. The Affordable Care Act is under huge attack, as you know. It's in jeopardy. There's no doubt about whether it's this administration or next. So anything you can do, and this is a personal request, to advocate for it, especially on the part of young adults who benefit already, the 6 million, of which 10,000 have been diagnosed with cancer and have insurance, and the more to come. And if we could raise that level from 25 to 30, 35, 40, we've got to move in that direction as a country, as a society, on behalf of our people, whether or not they understand it or not. There's just a publication, and I skipped over it, EPUB. I've forgotten the journal. I'll have to look it up, get it for you after the break, on how survivors of adolescent and pediatric cancer don't understand the Affordable Care Act. They themselves, who have benefited in some ways already, but generally don't know how it can help them. And they're actually negative. Their current general response, exceptions, is it's going to cost this country too much money. It's not going to help. It's actually going to be non-productive. So we've got a big marketing campaign to do. And of course, the marketing campaign on its side is so vast and voluminous, it's hard to tack it on. But if you don't do it, they'll have their way.
Great. Well, thank you all. That was a wonderful way to get started, and thank you all for asking great questions. We'll take a break now and return at 10:15 with session number 2. Thank you.